button now. And if we could all just have a conversation, or as long as everyone talks at least once, then I can make sure that your place is recording as well.
Okay.
I can talk a couple of times if you want.
I'm usually chatty.
All right.
Series of webinars entitled Supporting QI, and we are just very pleased to have you all joining us. So, as you know, we are the Excellence Through Quality Improvement team, and we're looking forward to sharing the next little while with you. We'd just like to take you through a bit of technical information. First of all, audio is available on your computer. If you cannot hear, please listen in by your phone, and please be sure to mute your line. The lines are here in the presentation. They are 1-888, sorry, I'm just moving the screen here a little bit, 455-1368 with an access code of 675-644-542. We are planning time at the end for discussion and questions, and one of the things that we will be talking about momentarily is how to pose those questions. After this webinar, we will provide the PowerPoint presentation. It will be emailed to you and also available on the Excellence Through Quality Improvement Community of Practice, where we will also have the questions and answers to those questions added to the webinar. At the end, though, because we are really focused on quality improvement, we're going to ask you to please complete a brief feedback questionnaire, because we do, in fact, want to make sure we're providing the best quality in these webinars and in an effort for continuous quality improvement. So, in terms of those questions, one of the things that we'd like you to do is in the right-hand corner of your screen, you can press a little red arrow at the top, which will expand the options that are available through GoToMeeting. There is a section that you can unfold by clicking on it where it says questions. We would ask you to please enter your questions there, and we will bring those up at the end. One of our team members, Jenna Hitchcock, will be monitoring those questions for us. So, we'd like to take a moment to introduce ourselves. I am Sandra Cunning, and I am one of the co-directors for the Excellence Through Quality Improvement Project representing Addictions and Mental Health Ontario. And I'm sitting here with my partner and very good colleague, Michael Dunn, who is the co-director for the project and representing the Canadian Mental Health Association, Ontario. I'd like to turn it over for a second now to Kim and Sarah, who are joining us from Kenora, so they can introduce themselves. Kim, Sarah, are you there? So we're not hearing Kim or Sarah, so I'm going to take it upon myself to introduce them. So Sarah Diaz is the Executive Director of CMHA Kenora, and we are most happy to have her join this presentation and talk about building a culture of QI within their organization. And Kim Elk is their Quality Improvement Specialist at Kenora and has also been seconded to the Excellence Through Quality Improvement Project to serve as one of our quality improvement coaches for the province. So we'll try to get that sorted out. So when it comes to their portion of the presentation, they'll be able to join us. So the Excellence Through Quality Improvement Project, which many of you, I'm sure, have heard about already, is an 18-month partnership between Addictions Mental Health Ontario, CMHA Ontario, and Health Quality Ontario. Really, we are focused on building upon the sector's existing commitment to providing high-quality and person-centered care to individuals and families. And when we say our sector, we mean the community mental health and addiction sector. One of the things that we've been working on for the last few months is to develop a menu of offerings to the Excellence Through Quality Improvement project. Really, it is based in the idea of peer support. That's why we have quality improvement and data coaches that are coming from the field, but also in terms of the folks in the sector and how they work together. So we are offering a series of opportunities for the members from our sector. So the first being primarily resources and our platform, which is the E-QIP, community of practice, which is an online community supported by Health Quality Ontario. Here, our members will have access to various sorts of training, resources, and conversations. Part of that access will include access to advanced ideas training, as well as access to the Institute for Health Improvement Open School. We also are offering various sorts of training, and today you're participating in the Supporting a QI webinar, and we're glad that you're here for this first official webinar. But we also are doing further support and some deep dives where we have over 30 initiatives that are being supported through quality improvement and data coaching from our quality improvement and data coaches that have come from the field. And we are supporting those 30 initiatives through agency, organizational coaching, as well as specific project coaching to help move particular QI initiatives forward. So what we are planning to offer in the Supporting QI webinar series are monthly webinars that are aimed at providing information, examples, and resources to really help the community mental health and addiction sector move forward and support them in their QI efforts. We'll be focusing on particular areas including culture, leadership, client and family engagement, tools and resources, data and measurement, and more. So one of the things that we do want to know is if you have any suggestions for any other topics that you would like to see, please be sure to email us at quality@equip.ca, and please feel free to email us with any question or thoughts that you might have as we look forward to hearing from you. At this point now, I'm going to turn it over to my colleague Mike, who is going to lead us through a discussion on quality improvement culture.
Hi there, folks. It's really nice to be joining this webinar and have an opportunity to speak with you, and also to hear from the folks up in Kenora. I'm looking forward to that. I just want to begin by offering a bit of a disclaimer because E-QIP is an extremely busy project, and we're doing a lot of engagement with folks out working in the sector. I have to leave at approximately 12:45 to catch a plane up to Timmins, so I won't be able to stay for the remainder of the webinar. But if there's questions that get asked that are specific to something that I talk about, and my colleagues would like me to speak to it, I'm happy to respond to you after this session on the community of practice. So we have three objectives for today's webinar. The first is to really illustrate the importance of culture in facilitating quality improvement efforts, and to demonstrate some of the types of activities and priorities that really fuel a culture grounded in quality improvement, and of course to highlight some practical examples and some tools that are being used in the sector. So what is culture? Well, when we think about culture, it's really the attitude and the beliefs that a group of folks have. It's something we can feel in our organizations in the way people act, relate to one another, communicate, and interact both with clients and other staff. And I think we've all probably been, at one point or another during our careers, parts of organizations with very different cultural feels. We've probably all been in organizations where we felt, they operate in a culture of crisis, fast-paced, trying to always catch up and really never getting there, with never-ending demands on our times and folks feeling, tired and stressed and frustrated. On the other side, we've probably all been in cultures and organizations where things are a little bit slower and methodical with lots of planning. People are encouraged to contribute and participate and opinions are valued. So you can really, I think it's something you feel, the difference in culture. And when we ask people,
Oh, excuse me, Michael, can you hear us?
Yes, I can hear you, Kim.
Excellent. Thank you. Sorry about that.
No problem. No problem. Glad you're on the line. If we ask people about culture in organizations or why things are the way they are, people may say, it's just the way we do things around here. And that probably sounds familiar to you. One thing we all probably know as well is, there's lots of pieces of legislation or requests that we face as providers of care and services. But how many of these pieces of legislation or these mandated requests really become part of the fabric of our organization and our system? We can take accessibility legislation, for example, or workplace wellness legislation. And there's really a difference between adopting these legislations in theory versus truly integrating them into the way we work and talk. It's that talking the talk versus walking the talk. The Excellent Care for All Act, if you're not familiar, is a piece of legislation that currently applies to the hospital sector, but there's a strong feeling that eventually it will be applied to the community mental health and addiction sector. And it requires organizations to take a bit of a focus on quality improvement, do things like quality improvement plans and have quality improvement committees. But I guess the question to consider is, will legislation alone, and this piece of legislation in particular, be enough to change the culture of our organizations or of our system to one grounded in quality improvement? It's important that we consider culture, because we can have strong pieces of legislation like E-QIP or well-articulated strategies, but if we don't consider the human factors, particularly the culture of the environment in which we're seeking to impart these strategies, they may get eaten. Harvard Business School did a survey of 2,200 businesses examining exactly that, the relationship between culture and strategy. And what they found was strategies can be well-planned and well-meaning, but can be killed by culture, particularly if strategies mean a dramatic change from the way people used to do things to a way that we'd like them to do things. And these results, I think, are pretty telling and apply to more than just the business sector. And I would suggest considering these points, when you think about your organization or our mental health and addiction system in general. So they found that 60% of the respondents think that culture is actually more important than strategy. And 51% said that they think that overall culture needs to be a consideration for imparting new strategies into practice, and only 35% thought the organizational culture was effectively managed. Furthermore, Harvard folks looked at the reasons why staff resisted change, and they found a number of things. That folks were skeptical due to past failures, and people didn't feel involved in the change process, and don't understand the reasons for change, among others. And that culture, if not addressed, can kill your change ideas. There's a fantastic book out for anybody who's interested called The Switch, and it's by the Heath brothers. And they look at change being like an elephant. And they say, if we're trying to do change, simply having a rider that's aware of the facts and the rationale and that strategy isn't enough to move the elephant. The elephant's motivated by the feelings, by bringing people in and feeling included. But you also have to shape the path and make things easier, tweak the environment so that change becomes easier for folks to do, reducing the resistance. And so I'm sure this is probably familiar to folks. I think I know I've been there. And in quality improvement, it's especially important that we consider culture if we want to do improvement efforts or impart our change ideas, and we want them to be sustained. We can get very excited about things, like hand hygiene practices, and wanting that to be something that we, achieve 99 or 100% compliance with. But if the organization, if there's not a feeling of safety, a culture of safety, and that being a priority for folks, then that is, that hand hygiene is unlikely to be sustained. And we have a tendency to revert back to, the way we always did things. So there's a great tool out from NHS in England called the Sustainability Planner tool, and we're going to link that onto our community of practice. And it's a helpful tool if you're thinking about doing a quality improvement project or a change initiative. You can actually answer some questions on this tool, and it'll point you in the directions of things you'd want to consider for sustaining your change. And it looks at things like how your quality improvement initiative or your change idea fits with the aim and culture of your organization, and are there areas for alignment, and are staff being included in the change idea, because we know that including frontline staff and people involved from the beginning will help you be successful. And also, how engaged is leadership and senior leadership, because that too can play a big role in setting the tone for the culture of the organization and helping to see your project sustained. So on the topic of leadership, there's folks here probably today that are here because you are leaders and you really believe in quality improvement and that it's important. So there's some special cultural considerations that we found in the literature from IHI and for others that we'd like to share. And this is just asking yourself 4 questions. You're thinking about your organization or about our health system in general. Is there a difference between what's said and what's done? We can see that happen sometimes if we hear that something's important and it's valued versus what's actually done in practice. And that can give you a good insight into the culture of your organization and the difference between what's preached and what's practiced. The second is the message believed? We can have great messaging out there, but are people believing that it's true and that the commitment is there? And encouraging peer involvement by asking, is there positive social pressure to improve? Do people believe this is important and they're going to encourage each other to adopt this change or this improvement initiative? Or is that something we want to look at? And are staff empowered to take ownership? So it's one thing to include people. It's another thing to empower people to really own a change or own a quality improvement project. And that too can really help tap into that culture that's happening within your organization and help your quality improvement project be successful. And I won't go into details too much about this slide, but point you again to that link at the bottom, which we'll share on the community of practice. It's a very helpful resource from IHI, and it's a white paper on the culture of quality improvement. But I would note one point from this slide, and that is that culture change is slow. And if we're trying to, as leaders, change the way attitudes play out into culture in our organization, it takes a long time. And it's suggested by this IHI white paper that start with the small behavior changes that are within our powers to influence. And again, it comes back to that whole elephant. Try to make it easy for folks, because through behavior change shapes attitude change, which helps eventually with culture change. So again, this is a helpful resource you may want to check out after this webinar. So we've talked a bit about culture and why it's important to consider culture with respect to change. Now we'd just like to recap a bit about quality improvement and what we mean by a quality improvement culture, because quality improvement essentially is a method to drive positive change. And you're probably well familiar with this slide if you've attended any of our E-QIP webinars or events. And this is a definition of quality improvement that comes from Health Quality Ontario, encouraging us that it's, quality improvement is not just somebody in an office that's a quality improvement specialist. It's part of everyone's responsibility as staff members and providers of service and care to continually try to look at how we're doing and get better at that. We ask our clients to make changes or improvements in their lives and to be healthier and strive for better outcomes. Examples such as harm reduction. So as providers, we should be doing the same thing. We should be trying to make changes within our services that can help our clients to have those better outcomes. And this definition here from Quality by Design I like as well, where it talks, as professionals, we have two jobs: to provide care, but also to continuously try and improve care. In quality improvement, we set our quality compass to the direction of what's called the quadruple aim. And that's really, our system aim, our common aim, to try to get the best care for individuals as possible, provide support to our staff who do this care, so that the care is provided as good as possible, with the hope of influencing a healthier community and healthier populations, and also being attentive, of course, to being as cost-effective and efficient as possible. So to get to that quality improvement quadruple aim, we need to have a systematic approach to making improvements in the areas that we think impact that quadruple aim, that better care for folks and better health for our communities. And those areas that we try to improve, we call those the domains of quality. And Health Quality Ontario has set these out pretty clearly. And these are the areas that we try to improve within our power. Things like safety, efficiency, equitability, timeliness, efficiency, and person-centeredness. And of course, we need a method to try and improve in these areas. And this is where the model for improvement comes in. It's just one method. I mean, people may be familiar with things like Lean or Six Sigma. All of these are additional methods and tools that can help drive forward those domains of quality. So in that way, quality improvement is really about a model or methods to do QI and to test change ideas with our hopes of improving those key domains of quality, with our end goal being that of the quadruple aim. And it's a continuous process, and it requires us to be willing to change how and what we do and how we look at things on a continuous basis. So as we know, it's not enough to have these great models and these tools, but we must also pay attention to those factors that support adoption of quality improvement and of these models. And Ross Baker here at U of T did a great job a few years ago at looking what factors really support the success of quality improvement within healthcare organizations. And what Ross found was really these top 8 attributes that support the success of quality improvement: culture, having strong leadership, strategy and policy, having a structure that's supportive, having resources available for folks, and having a clear information system, including things like capturing data and communicating that out, and having communication channels so that folks have a voice and can be heard with their ideas, and of course offering skills training on a continuous basis to our frontline staff. And just as a side note, these supportive attributes have helped to form the basis of this QI webinar series. So our eight of our webinars will focus specifically on areas related to this. So our picture starts to look like this. And culture is really one of the most essential supportive factors to sustaining and building quality improvement. And I kind of like to think of it like this because I'm a bit simple this way. That is, our destination is that quadruple aim. It's the healthy staff and clients in our community. And our domains of quality are our roadmap to get us there, telling us what roads to take on our QI journey. And our model for improvement is our car. It's the machine that works, with lots of interrelated parts to help to get us to that destination. But of course, that machine needs oil and gas and coolant and things, and those are all of our supportive factors that help keep our QI machine running. In April to May of this year, the E-QIP team had an opportunity to take some time and engage with the sector through a series of surveys, interviews, and consultations to get a sense of the QI landscape in the mental health and addiction sector across Ontario. And we used the Ross Baker factors, those factors of culture, leadership, structure, etc., as the basis for our questions as we looked at, where is the sector in terms of QI readiness? And what we found were really four profiles of agencies that we met with and talked with. The first being those at the exploration phase of quality improvement that have a commitment to QI, don't have a lot of staff training, no dedicated resources, and maybe have some challenges with things like data. To installation, those who are highly committed, have some training, but don't necessarily have dedicated resources, and you could use more training. To implementation, folks with history of quality improvement who do things like annual quality improvement plans, have quality improvement resources, but maybe those resources aren't secure and they're not integrated as much as maybe they would like into the rest of the organization. Up to those who are full adoption with a strong history of quality improvement, and it's embedded really in the fabric of how they do business. And those are our sector leaders. And of course, part of this survey was looking at quality improvement culture. And what we saw was that those agencies that are at the full adoption, the top, really had four important things that we noted. Agencies that promote learning and innovation, that have a strong history of quality improvement activities, and they have employees who are empowered to not only take part in quality improvement, but to lead it, and leadership with a strong vision for what quality means to the organization and what it looks like. And what we found in our survey was there's really a mix across the sector, pretty much a four-way mix. So getting back to our model, our quality improvement model for a second, I wanted to talk about from the research, both at IHI and through U of T and Ross Baker and others, I wanted to talk a little bit about some of those factors that help support us building that culture of quality improvement. And these are, of course, aligned with our findings from our survey across the sector. So these really are key ingredients to building that culture that supports the model for improvement and doing quality improvement work. So the first is developing a vision for quality. Really setting that compass, where are we going with our quality improvement efforts as an agency or as an organization, and why is this important to us and our staff and our clients? Setting that clear direction from the outset seems to really help influence the culture in a positive way. Secondly, dedication to quality improvement and safety. And this is something that's important on many different levels in an organization. Right from senior leadership and boards down to managers to frontline staff. Having champions at all levels who can help influence others and really promote the value in paying attention to safety and making quality improvement something that happens throughout the organization. Thirdly, supporting change and understanding resistance. And resistance is normal. And in quality improvement, it requires us to think quickly and to be open to change. And again, I keep going back to that elephant example. And we'll link some resources on the community of practice, particular to change management, that may be helpful for folks. And number 4, using data to guide decisions. Improvements should be based on the best data that we can gather. And it's okay that data may not always be perfect, and it may be local to our organization, and that's a good thing. But I'm sure we've all been in situations where changes have been implemented. We don't really understand the reason as to why or the data behind it. So having a strong data foundation is critical. And number 4 is allowing for innovation and empowering folks who do the work to tell us, what ideas do they have that we can change and improve upon, and allowing for innovative and different ideas to be piloted. Number 6 is supporting human factors. So learning about things like the importance of social structures and peer support within organizations, and the power and influence that folks can have on one another. When you have strong champions, they can help influence change in culture change. Number 7, end user participation. So not just token client surveys, but actual meaningful involvement. And we heard from a lot of agencies that that have service users on their board of directors, have things like advisory committees, and explore different ways to get feedback on different initiatives or changes or quality improvement projects from the beginning, not just from the end. And lastly, continual learning, recognizing that that's something that happens from the top down. Our system is constantly moving, and our sector is constantly changing. So being open to learning new things is also critically important for helping to build that culture of quality improvement. And so we'd like to hear from you about this and your experience in your agency with respect to culture and what you found to be most helpful in supporting a culture that's dedicated to quality. And are there resources or tools or suggestions that you think others might benefit from? And we'd ask that you share that on our community of practice after this session. Now, we had an example that we were going to share with you, a short video. It's about 2 minutes long, from an organization looking at really a quality improvement in safety culture. And we were all set to do this today, and then in our test of this webinar, the volume wouldn't work. But that being said, I'd encourage you to give it a watch. It is only about 2 minutes long, and it's quite good. And pay attention to what the speaker has to say and how it aligns with those factors that we've talked about in building that quality improvement culture. And you'll hear him say things like, it's the focus of the organization, and it's the safety of the care we deliver, and the spirit of discussion, not blame, and things like that really speak to that culture, that culture of quality improvement and safety, and it aligns well with these factors. And these were some of the key points here in red and blue that we noted he said in that video. So it might be worth taking a few moments to watch. So hopefully this has been a little bit helpful, and I didn't want to take up too much of the webinar time on the theory and research, but instead hear more from CMHA Kenora, as well as some work that's being done at Health Quality Ontario. So I'm now going to pass it back to my co-director, Sandra Cunning, who's going to talk a little bit about the work at Health Quality Ontario.
Thanks, Mike, and we wish you a good and safe trip on your travels with the work with the E-QIP. So we're very fortunate to have E-QIP funded and supported from our partners with Health Quality Ontario. And we wanted to talk about kind of the foundational pieces that they offer to this project. Back in 2015, a report was released called Quality Matters, and it was produced by an external committee of advisors that was tasked by HQO to produce a plan for quality in the system. And what it really does is it helps lay out or set out a framework for quality for the province. And what you will see on this main slide is a definition of quality, a set of principles, and then key enablers that will really help drive a high quality system. The report was motivated by a sense that and we see this also within the Community Mental Health and Addiction Center, that while many people are engaged in improvement efforts, it's sometimes very hard to move that needle forward on your own. And so part of the idea around this report is that we have a common language when we talk about quality, and then we have a common shared set of goals for the system so that we all can kind of be working towards them. One of the things in our travels, we've been talking about this a lot with our providers in the community mental health and addiction sector, are these key domains. Mike addressed them earlier, but this idea that we have safe, effective, client-centered, efficient, timely, and equitable services. Since the release of Quality Matters, 3 smaller working groups have been working on a draft of additional chapters and recommendations on some key themes that have emerged during the committee's work. The other piece that we want to kind of highlight in this framework are the principles. And again, regardless of where we have traveled in the province and who we've talked to, we really see these principles coming forward as key kind of drivers and guides for the work. And finally, in keeping with the idea of a culture, how do we actually foster a culture of quality across the system and within and between organizations? And the group has addressed a few key enablers of culture. We talked about already this idea of the importance of leaders who can help champion quality, resources and investments in supporting quality improvement, of which the Excellence Through Quality Improvement Project is one of those investments. And clients and clinicians meaningfully engaged in building cultures focused on quality. And Health Quality Ontario is helping to support and drive many of these key enablers. And the ways in which they are doing so include quality standards, quality rounds, reports and white papers, one of which we've referred to earlier, common tools and resources, which is what we will also be mirroring in the Excellence Through Quality Improvement Project on our community practice, which is listed below, and the Health Quality Transformation Conference, which took place recently in October. So we again encourage you to visit Health Quality Ontario and look at the work that is going on and access the resources that are available. What I want to do now is turn it over to Kim and Sarah, who are really wonderful partners in the E-QIP project, but also in terms of providing some real-life examples and resources relating to building a culture of safety. And I'm going to turn it over to you now, Sarah and...
Okay. Thank you, Sandra. And I hope everybody can hear us now.
Yes,
okay.
We can.
Excellent. Thank you. I think I just need the controls for the webinar.
I think they just came to you.
Okay. Sorry about that. You gotta love technology. Interesting. 1 second. Huh. Okay. Where's the screen? Sorry about that. My screen just disappeared. Okay. Well, as long as you can hear me. Oh, here we go. Sorry. I don't know when.
Here we have them here if you want to start.
Okay, I might have to get you to change the screens, Jenna. Sorry, my presentation disappeared. Anyways, so here at CMHA Kenora, quality is definitely embedded into our organizational structure and culture. Client safety is one of our organizational strategic directions, and it also nicely aligns with the HQO quality domain of safety. And on the next slide,
we're hoping that somebody's changing the slides.
Is it working?
We're working on it. Sorry.
No,
no worries.
That's okay.
No worries.
That's okay. Oh, here we go.
We're back up.
I have control.
Hey, can you
So when we're
now?
looking at safety critical industries, certainly we believe that healthcare is one of these. And on our next slide, you'll see that we have a quote from the International Atomic Energy Agency, stating that an organizational atmosphere where safety and health is understood to be and is accepted as the #1 priority. Oh, good, we're working now. Excellent. Other agencies, so a culture of safety is paramount to a number of safety critical agencies, so much like the Atomic Energy, to NAV Canada. Certainly there, and NAV Canada is actually, they're providing a lot of leading practice in the area of safety and focusing on transitioning from a blame to a just culture. And for obvious reasons, when we're flying, we want to have faith in the system that people are reporting errors and that they're being analyzed and prevented in future incidents. And then
okay. Are we controlling?
Yes, you are.
Okay, great. Okay.
Thank
Hi,
you.
it's Sarah. So as part of some of the elements of a culture of safety is really ensuring that you have good commitment from leadership in regards to safety, and ensuring that sort of shared and values, beliefs, and the behavior of leadership when you're really modeling for frontline staff. So communication is absolute key in regards to ensuring that you're creating this culture of safety, ensuring, as a leader, you're creating a vision, not only through frontline, but as well as the governance level, and ensuring that you're providing examples of good safety sort of a culture versus bad safety culture, which is something that we've worked on for the last 3 years here at our organization. But in order to do that, you have to be able to ensure that there's resources allotted for people to be able to do the quality work that they need in regards to ensuring a culture of safety, and providing some rewards and incentives in regards to ensuring people are feeling valued in what they're doing. As the majority of our frontline staff, when we started this rollout, we're really focused on direct client care, which is extremely important. But there's also the importance of ensuring that direct client care is also delivered in a safe manner. So how did you sort of balance that was a conversation that we had organizationally. And ensuring that safety is paramount and is a priority. And we have this as a strategic direction, just like Kim had indicated, and that's part of Accreditation Canada standards that we need to have that. But as well, it also allows us to leverage sort of that vision within the organization in regards to ensuring to maintain safety as a priority. And like I'd indicated, communication at all levels is extremely important. Openness about ensuring to report problems, as well as discussing sort of the 5 whys of why things sort of occur, and sort of walking through that process without ensuring that you're labeling it as a performance issue, but more of an issue around system issues, as well as then using that as a learning mechanism for staff. And I'll go into a little bit more detail about how we've done that as an organization as I move forward. Oh, so sorry, here we go. So here at our branch, there was a huge shift in regards to building this culture of safety. When I initially started as executive director, it was a very punitive approach, and so that culture was really one of fear. There was not a lot of incident reports being shared. Client safety incidents were kind of being pushed under the rug, and so there was a lot of work around ensuring that we were building a culture of learning, a culture of openness, and a culture that really focused on communication. Thanks, Kim. And in order to do that, we had to ensure that we moved from this blame culture and moved from the fact that we were initially looking at client safety incidents as an area of human error, which is not what our focus was. There was a lot of discipline going on in regards to client safety incidents that were reported. So we wanted to ensure that we were not focusing on fear and blame, but looking at a system-wide approach to incident reports. So in order to do that, we had to really focus on training of each frontline staff in regards to looking at what a just culture looks like, and really doing that in a forum that allowed staff to do that without leadership present, but as well as with leadership present at times. So we really focused on how to develop communication between teams and how to promote that safety amongst teams, because if we didn't have that at the team level, we weren't going to integrate that across the organization. So once we developed sort of that team approach in regards to culture safety and those conversations that occurred between teams, that really started to leak in towards the organization as a whole. And when I say that, it started to leak in regards to our quality improvement teams that we had going on. It all started to leak into the management sector, and then it really started to leak into the governance level. And we used all of this as in regards to learning in adverse events. So what we did was at each of our annual general meetings, we take the time to review our quality incidents and look at sort of what the top sort of offenders are in regards to incident reports, and really talk to staff and our governors as well as our leadership about what it is at a system level that we can look at changing those top issues that we were seeing throughout that year. So we really looked at investigation of why these things were occurring and how we can support staff as well as clients to be able to develop a better organization that focused on a just culture for safety. So in order to do that, I've mentioned before, we had to really balance accountability and learning. And how we did that was ensuring that people were looking at client safety issues as a system issue and not looking as a performance issue. So we really had to focus on really educating our staff around what was occurring in the system, what some of the barriers are in the system, and allowing them to walk through that because they weren't privy to a lot of that information before. So it was a lot of education pieces from leadership for them to understand sort of why there wasn't access to certain specific treatment, for example, within our region, and how that impacted client safety within our organization and for our clients, of course. So really, there's been a lot of growing pains for our organization. I'm not going to lie; it has not been easy to be able to shift from a culture of blame to a culture that's just. But in order to do that, we're really ensuring to make staff feel as if they're able to grow in their roles as frontline staff, being able to ensure that managers feel as if they can manage effectively to be able to manage the issues that are identified within their teams, and then coming together as a management team to support the organization as a whole, and not just owning incidents in one team versus another, owning it as an organization. And then having the board of directors really having conversations about how some of these incidents can be used to be able to support system impact within the rest of the province. So our journey first began with not only changing the culture, but then changing the frameworks that we used internally. So we did this by looking at different methods and tools that we were using to analyze safety incidents. So like I had indicated, we really asked the questions of what happened, how and why it happened, what can we do to reduce the likelihood of occurrence for self-care, and what was learned. So that's the initial approach that we used, and this really assisted staff to be able to change their outlook in regards to how they analyzed culture and the incident reports that the agency was being faced with. So what we did is we started our journey with starting to train everybody on the Canadian Patient Safety Institute frameworks. And so as an administrator, we started with myself getting trained to really be able to mentor people throughout this journey. And now we've allocated resources to be able to train all frontline staff on this CPSI sort of framework. And so now we've trained our chair of our Client Safety Committee, and we're going to be training each team slowly in regards to this framework. So throughout this process, we looked at the decision tree that CPSI has in regards to incident analysis. And this really has changed how our client safety committee looks at incident reports, because we were just having conversations initially about what was the incident report, how it happened, etc. But we weren't looking at, was this really a system level issue, or was this really another sort of management guidance issue? So this framework really allows the team to be able to go through the incident with asking questions from the service providers that are involved, as well as the client, and really identifying, is this really a system issue that we need to look at, or is this more of an internal process that we need to look at? So this framework has actually been quite enlightening for the team, because it puts it into perspective on why action steps have been taken.
And I just wanted to add another, this is just one example. We like the CPSI framework, but here's another example from BC Patient Safety and Quality Council from their Culture Change Toolbox, which will also be in the community of practice. And it just, it kind of has the continuum on the bottom that shows, the continuum between individual responsibility to system failure. So it's just another way to articulate this type of theory.
So as indicated, our agency, one of our strategic directions is around client safety. And so it has indicated we also adapted the Canadian Patient Safety Institute Incident Analysis Framework, and all of our policies follow the Canadian Patient Safety Institute processes. And we implemented this about 2 years ago, so we're just seeing the effects of the training and implementation pieces now on moving from this culture of blame to one of a just culture. As well as now we're evaluating our framework and ensuring that what we intended to do is actually effective in what we're doing. So Kim is working with the organization now to do a PDSA cycle to ensure that our evaluation piece is demonstrating effectiveness in regards to providing safer client care. And we're going to continue to evaluate. There's pieces that we may be removing, but we're not sure because we're currently in that process.
Yeah, and we've been doing PDSAs all the way through and streamlining this process as we go.
Perfect. So the incident report analysis form is there for you. I'm just going to quickly walk through it for you, but we've developed this as a way to streamline how committees approach client safety incidents, specifically from the administrative level to the client safety committee level to then the quality improvement level. So there's a code on the side there is a key on who is identified where in regards to what responsibility they have. So as the administrator, I have the responsibility of all the blue areas, and I think on your screen it looks more teal. I apologize, it could be any color to you, but I think it's teal for you. So as the administrator, once a client safety incident has been provided to me by a manager, my responsibility is to go through the teal areas to be able to identify what's the outcome, so what are we labeling this incident as, what's the action steps that we've taken immediately after having conversations, who's responsible, what's our sort of target date for completion, and have we received the appropriate documentation as indicated for action. Our Client Safety Committee then will look at sort of what the category of the incident is, where the incident originated from, which program level, the location, was it community as we're a community agency, or was it at somebody's home, was it inside the building, where was the actual incident? And then we use a risk assessment analysis framework that we have, which we haven't included in the PowerPoints, but really looks at the probability of how an incident can occur again, and what do we think is the actual frequency of it potentially occurring again, based on illness, based on continuum of where clients are, based on what we have for service options, based on how we've partnered with other organizations, etc. We talk about how that severity can impact sort of our outcomes. And then our quality improvement coordinator, after each quarter, will ensure that all of the event follow-up statuses have been made, and that each agency has, each committee and the administrator has actually done what they've indicated that they're going to do.
Thank you. And of course, tracking data is essential to this process. So we developed, it's basically Excel-based, we're using the data list functions, and we have an incident report analysis framework. And our framework, our analysis form, which you saw, and also our incident reporting form, all share uniform language and format, so they're all connected quite well, and it has good flow and it's easy to follow. Additionally, we've tied this framework into other strategic documents within our agency. So this ties in with our strategic risk management plan, and we use the same tool. So we have a risk register that we use on our risk management plan that looks at probability versus seriousness to evaluate the impact of an incident. And so we keep some continuity. Instead of using another tool, we use the same tool. And so we're trying to, and it's basically an A to E tool, and anything that's obviously A, B, C are more likely to occur and have greater impact. So we're going to try to problem solve to prevent this from occurring again. As well, this information from the Incident Report Analysis Framework is reflected on our balanced scorecard or strategic indicator dashboard, and it's also on our quality improvement plan. And it certainly is important to remember when you're adopting a quality culture to have a strong connection with any projects you're rolling out. You need a strong connection to your organization's strategic directions. You really need to close the loop and make sure that everything's interconnected. So kind of a good analogy, the way I like to think of it, if anybody's ever worked with an interior designer before, they always ensure that the motif of one room or all their rooms ties in or flows with the rest of the house or building or the project, and so that there's an interconnectedness or a flow in the design. So basically, when you're looking at your frameworks and QI projects, they have that same flow. So again, the cornerstone another cornerstone to a QI culture is measurement. So not only do we measure outcomes to change ideas, we also try to measure the culture itself. So there's various tools that you can use. I put two tools in the slide, one from Accreditation Canada and one from the IHI. I'm just going to touch on the patient safety culture tool from Accreditation Canada, but we will have information on the community of practice regarding the IHI tool. And so essentially, this tool helps to inform safety practice and evaluate staff perceptions of how their organization approaches client safety and reports safety incidents. So the way the tool is set up, it's grouped into various themes. So you have leadership support, communication, judgment-free, repercussions to errors, incident follow-up, the design, the learning, and then the overall kind of grade of your agency's safety culture. So I won't go into too much detail. It'll be on the slides, but afterwards you get basically a dashboard where when you're scoring poorly on an area, what we do at our agency is we focus in on those areas, and we want people to feel safe in reporting, and if they're not, it will come out in this tool. Yeah. And so that's just a few of the other questions. So key ingredients to a QI culture. Well, of course, center to everything that we do is the client and family involvement. So we really made a lot of changes over, and partially driven by accreditation. I mean, we've always been client focused, but now the changes by Accreditation Canada is a client and family philosophy of care. So we're really having more formal workflows involving client and family, and involved in how we make changes to our programs and our care. So we have a client family advisory committee, client perception of care surveys. I'm sure a lot of you are familiar with the OPOC. And so why client and family involvement? I mean, really for all those obvious reasons that we're aware of. So it builds knowledge and skills and confidence to manage their own health, resulting in improved health outcomes and reduced health services. It helps to build strong relationships with their healthcare providers, and they're taking part in decision making, resulting in improved decisions and better experiences. So really focusing on that autonomy piece and ownership. And it also identifies opportunities for improvement in their care early in the process, and so looking at better risk management and increased safety of the client and family.
And so this next slide is a wonderful slide because this really, really provides a good synopsis of how leadership and staff engagement is really successful. And in order to be successful, a leader needs to ensure to motivate, coach, inspire, teach, provide, effective teamwork, vision, lead by example, and really mentor. And that's sort of been the success of our implementation of a culture of safety and continuous quality improvement, is ensuring that not only as an administrator, but as well as our management team are doing all of those components. And what we have done, and Kim touched upon a little bit around, is the person-centeredness. So, we took the philosophy right from the get-go, nothing about me without me. And so we ensure to put clients in regards to our improvement teams. Like Kim had indicated, we do have a client and family advisory committee, and we are now vetting all of our HR practices and our incident reports through this particular committee, and ensuring that we have the lived experience in regards to any recommendations that we should be making in regards to program development. We also need to ensure frontline engagement. So our quality improvement team not only has the administrator and team leads, but also has frontline engagement involved in the quality improvement team. So all of our QI team members that are frontline have been ongoing training for the IDEAS program, for example. They're pulled into any of the data quality projects, and really understanding how data is inputted, the effectiveness of good data inputting, ensuring they understand how data is accumulated in the system, because it shouldn't rely just on the administrator. Staff need to understand how their inputting impacts the quality of the data that we're seeing. A real focus on clarifying priorities within the organization, really looking at a provincial level, at a system level in regards to our bodies of accountability that we have in our organization, and really being transparent on where those things are going. So staff have an understanding of why changes are being made, and ensuring that they have an input into that. Transparency, looking at both the good and bad. Sometimes we tend to focus on the bad stories, but there's also very good stories on very good preventative measures that staff have been engaged in, and really bringing that out in regards to our sharing, and really looking at quality results. So as indicated before, we do this at our AGM. We also have a mandatory winter meeting where we bring staff together, and we have conversations about, what's our quality improvement plan saying, what's our incident report analysis framework saying, and how can we use that in regards to development of our operational plan moving forward within the next year, and really getting that staff input. And then ensuring that we're being boundaryless, looking at a continuous improvement among all programs, not just in departments. And really understanding that, we may be in our own separate programs, but it's really about agency-wide continuous improvement and how we do that effectively. So my last slide is just really about managing the unexpected, and what our organization has moved to is a prevention approach to care, and really looking at taking adverse events, analyzing them, determining how we're resolving them, and really looking how we can attempt to try to really potential any future problems that may be coming, and how we really can be proactive in our approach in regards to client care.
Okay, thank you so much, Sarah. So it's going to take a minute. I think Jenna is getting some questions together here. Okay, let's see.
We haven't had any questions in the box yet, so we'll give participants a few minutes to take them out, and then I'll send them over to you, Kim.
Okay, great, thanks. So maybe I'll just go and talk a little about, or Sandra, did you want to talk about the community of practice, please?
Sure. I'll just skip ahead. So we mentioned our E-QIP community of practice earlier. This really is a great opportunity, again, provided by Health Quality Ontario, where we can bring our projects and our sector together around quality improvement within the community mental health and addictions world. On our community of practice, we will have resources. We will be posting all of the resources that we shared today, including other resources related to the project and tools that people are using out in the field. We also want to have this as a platform where we can engage in conversations. One of the most important things I think that we learned in our engagement work in our early visits was how important it was to be able to have people sit and talk about the things they're doing, learning from each other. We were recently doing an ideas training in Renfrew, and it was a fabulous experience where we heard providers talking about their services and sharing examples where they might not have otherwise had the opportunity to do so. So really making sure we create space for that. We will also have our coaches who will be online providing support and including things like support through webinars like this, which Kim, we are very grateful in your leadership around this webinar. And peer support. Again, getting people connected, helping with learning opportunities for things like accreditation, etc. You can find the link down there. Currently, and Jenna, you'll correct me if I'm wrong, we are in the process of onboarding our advisory committee and our project teams and getting them set up, because this will be a primary avenue for our projects that are receiving support and our organizations that are receiving support right now through the project. And then we will be looking to onboard other members of the sector later on. Did I get that right, Jenna?
Yes, thank you.
Great. And Jenna, and also speaking of Jenna, Jenna has been absolutely crucial and critical in this and has put in a tremendous amount of work with folks from HQO to get this platform up and running. So thanks so much, Jenna, for all your time and effort in relation to this. So we talked about this, things that will be shared on the community of practice, the presentation slides, including any other information or questions that come up and our responses to those. The NHS Sustainability Tool, the tools and frameworks that were mentioned today, and any other resources found in this presentation, including things like white papers, etc. We would encourage you to, if you have the interest to learn more about E-QIP, you can connect to us through the following websites. We also have connections for myself and for Michael. You can feel free to email us at any time, and we look forward to hearing from you. Please also feel free to tweet. You'll notice there's a little tweet, hashtag E-QIPON. We'd love to hear from you that way as well. So if there are any questions that have come up, perhaps we can look at those now. Has anything emerged, Jenna?
Yeah, we have one question. It's Kim. It asks, it provides some excellent feedback, thank you, and it asks, can you provide a specific example of an incident, leaving out information obviously, and how you worked through it using the tools you described? Why don't I just work backwards for a minute using the tools that I described. So basically, like, one would be an example, like we had a lot of medication omissions last year for the 2015-16 year, and that sort of emerged from the database. What we do, because it's an Excel data list, you can like pull the data so many different ways. So we knew our top 3 incident reports were, and we kind of did aggregates. We did medication, we did suicidal behavior, which tied in with our suicide strategy, and then it was falls. So what we did from there is the Client Safety Committee, we did a fishbone analysis on that, and we made changes based on that. And actually, we still have a project charter that we're working out on it. But what we would do is with each individual, I'm not sure if you're asking like how we run each individual incident. So every month, the Client Safety Committee meets, and we go through all our incident reports, and we apply this framework. So we take her, I'll just go back to the, oh, I don't think I'm in control anymore. I don't know if it's possible to go back to the incident analysis form.
Sure, I'll click us right back.
Yeah, so we would get the, a little bit more.
It's a little slow today, kind of like me.
One more and
One
then we're
more?
good.
There we go. How's that?
Thank you.
No problem.
So this would go to the executive director first, because our executive director also holds a clinical role, and that might be different in some other agencies as well. So the ED would put it as a harm, no harm, or near miss. So would define the category outcome. And then the ED would put the initial action items, because of course we're not going to wait on the incident until the Client Safety Committee meets. And then when, so as you can see, so she would take care of all the teal areas. And then monthly when we meet, we go through the incident report binder. We're still paper right now, but we're eventually moving towards putting this all paperless and on a database. But again, lots of PDSAs and one step at a time. So then we take the incident report binder to the Client Safety Committee, and then we go through each incident report individually. And we have specific categories that we've defined for incidents, and that's fluid. It's
maybe just identify the medication, how you would go through that. So
oh yeah,
as
thank you. Yeah, so we would put say medication omission would be the type of incident, and we have different. We have medication error, medication. What else do we have? Gapping. We have 4 different medication categories, though. So it would be medication / omission, and then we'd have the program that it occurred in. So this would be in the Kenora Supportive Housing, and the location of the incident in this case would be Kenora Supportive Housing, but it could be in the community, it could be in the agency, it could be in the client's home. And then we go through, each member of the Client Safety Committee has a laminated form, and then we look at the risk severity assessment. So using a risk register from our risk management plan, we rate it. So we look first, what is the likelihood of it occurring again? So with the medication omission in this case, we put it as high. And then we rated the severity. So depending on the type of medication, we would base the severity.
And everybody has an input into regards to the risk registered and the discussions of impact and probability. And so what happens is at that point is there's an examination of what policy and procedures are in place, what type of communication level is in place, etc. And all of that is discussed in order to base the decision of that sort of that conversation about risks.
Mm-hmm. And at this point, we will look at the action plan too. So we'll make sure that target dates have been completed, and we will make sure that that's on track. And there might be follow-up action items from the meeting to make sure that's followed up on. And then from there, you can see on the right middle, you'll see decision tree outcomes. So there's system improvement review or accountability review. So that's when we move through that decision tree that we showed earlier. I don't know if you can scroll. I think it was back, the decision tree.
Yeah, it was back.
Back, yeah. One more. To the CP. Yeah, there we go. So then we'll look at then we'll go through the algorithm, and then we'll come to the conclusion, was this more of a client issue that we need to work on their care plan? Was it a staff performance issue where you're getting into the substitution test questions, or is this just a system failure? And in this situation, it was a system failure because there was a breakdown in well, I mean, we've learned since our fishbone, and it's more of a communication issue. But that's where.
So through that analysis, as we went through this, it was identified that there was some missing procedures in place, and that there was communication issues between two programs within the organization, and we really looked at sort of where some of the process mechanisms failures were within both of those. And so it's really enhanced now how we approach medication omissions, and since we've introduced this, there's been an extreme reduction in regards to medication omissions.
Mm-hmm. And then the last portion, quality will just follow up and make sure that they'll do a final check with the quality committee and make sure that everything's complete on the incident, and if not, they will have individuals follow up on those action items. I hope that adequately answers your question.
We thought that would be a simple one, but hopefully it was.
Sandra, I think the second question is, I think is a good one for you.
I actually can't see it. What is the second question?
Sorry. See, I find it disheartening that HQO chose not to focus on the domains of work-life integration and adequately resourced. These are both so critical to the MHA sector. Any insight into why these were excluded from the HQO focus and how we may advocate to get them included?
That's a really good question, and I think actually I can't speak for HQO. I'm not sure if anybody is on the line right now who might be able to respond to that, but I think one of the things that we are kind of really focused on also, and I know that HQO, you know, they connect to this as well, is the quadruple aim framework. And one of the key elements that's been added to quadruple aim is improved provider satisfaction. And one of the things that we've been really mindful of in including in our vision is really taking into account to support our providers who do a lot and sometimes with not a lot. And so that's something that we are definitely paying attention to. I think if we shift the idea of patient-centered care and we think of person-centered care, person-centered would also include providers as well as carers and family members. So, so that I think is ever mindful for us in the E-QIP project. And I'm not sure if that answers the question, but we definitely have that as key on our agenda for our vision, and in keeping with the quadruple aim.
Okay, and we have a third question here. My question is, have you learned any best practices or identified any formats that could have been most effective in communicating quality work outcomes to all staff and clients?
Do you want us to answer that, Sandra and Michael, or?
Yeah, how about let's tag team this. I think you have some ideas and we have some ideas here.
So, you know, from an administrative perspective, in order to be able to ensure, you know, staff are well informed, is you need to ensure you're communicating well at all levels, and you need to ensure that you're communicating the reasons why quality initiatives are moving forward. And we've learned a lot about that because as we move forward, we were trying to do quality initiatives without including frontline staff, and that really backfired in our face. So we really learned that if you don't include them, you have to take the same approach. Nothing about me without me, with staff as well. So we ensure to communicate all of those reasonings why we're moving around quality initiatives, and look at the outcomes and really ensure we're tying the outcomes to why we're moving to the next step. So that's sort of what I would recommend.
And if I can add to that too, from a QI perspective, I find that the quality improvement plan and using a balanced scorecard, like both of those dashboards, I find they're an excellent communication tool, and it's a quick visual to see where we're not meeting our goals, and it shows us where we've been and where we're going, and we have that on our shared agency drive, and that's available to all staff. And the staff, you know, because they're developing quality indicators within programs, and there's a lot of ownership involved in that as well. So I can't say enough about having that as just like a great organization tool, communication tool, very effective. Sandra, do you have anything to add?
Yeah, we've been fortunate in some of my previous work. I think there were also a lot of different opportunities to kind of think about how we share information. So some of our organizations who are doing quality improvement work have kind of morning huddles or weekly huddles where they check in on things that they're working about, where they just kind of do a scrum and have their key pieces up around what they're reporting, what they're doing, and then reporting back on those things. That works well for some organizations. One of the other key ways, I think, is in kind of supervision when you have team meetings or when you're doing clinical supervision. I mean, quality can happen at a lot of levels. It can happen at an activity level by simply rearranging or restructuring kind of the physical space, for example, to make people feel more welcome. It can happen at a programmatic level, and it can happen at an organizational level. And each of those probably is more suited to different types of communication. So the ones that have already been mentioned, but also in those moments in team meetings and clinical supervision, we had an interesting conversation today about this in terms of we were talking about clinical supervision and people coming in and looking at a case and then trying something out, maybe if they were stuck after doing that supervision work, and then coming back and kind of talking about it and seeing how it worked. And in essence, that's kind of a PDSA cycle, if you would, the Plan, Do, Study, Act. So there are a lot of different mechanisms and opportunities, I think, for those kinds of conversation. I think finding the one that fits best to your organization and existing communication pathways that are effective, as well as the nature of the project is really important.
Okay, great. Thank you, Sandra. We have another question. It's more a technical one. Do we need to register with username and password to access the community of practice?
Yes, so what we'd like to do is have people send in a request. You can email Mike or myself, and I'm looking for our E-QIP email that we can send out as well. Please send us an email, and we'll happily add you to our list.
Okay, great. So the next question we have, are incident reports the only tool that can be used to address the blame ... framework? Some agencies don't have many incidents. They don't directly use like medication, deal with medication. I mean, there's other ways to look at safety. I mean, the Client Family Advisory Committee, the Client Perception of Care surveys, and in looking at you might want to...
Yeah, this is, I believe I'm understanding the question correctly, is sort of how can you approach this culture of blame to one of a just culture. And no, you don't need to just use it in regards to, what we've provided in regards to the Canadian Patient Safety Institute. That was just one example of how we started our journey in regards to changing the culture. But as an administrator, I would say that there's definitely different areas that you can definitely implement this. One being, I would suggest, like in HR practices, as well as a team building exercises as well. We've also looked at using, and this is just a kind of an interesting one, is we've changed even our agenda and our agenda processes and how we deal with team manager meetings in regards to not only the managers but as well as the frontline staff. So we include within those agendas ensuring that we're addressing work-life balance issues, as well as ensuring that we're providing an area of praise in regards to staff on what has been done well for that week in regards to client and patient safety care. So that's one way that we've been kind of changing, just to sort of on a brief technical note. I hope that kind of answers the question.
I think some of the things we've been also exploring, and when we did our diagnostics session last week, one of the things that we looked at was experience-based co-design. where you are also walking through things with consumers and using methodology to really engage and understand the experience. So sometimes if there aren't a lot of incidents, maybe there's maybe there is a place to look at opportunities where things can be improved or understood in a different way. So there are, I think, a lot of different approaches to be able to think about this work from a safety perspective.
I think the biggest thing I would add is that you know, coming from a level that you know, I walked into an agency that had a very punitive approach to incident to basically culture in general. To trying to shift that is really developing that trust and motivating staff to be able to partake in that system level work, because then they feel like they're a part of something.
Mm-hmm. Yeah, and some of our best ideas come from our staff.
I agree.
Mm-hmm. So, if there, it looks like, are there, oh, one last question, and then we'll wrap it up. Do you incorporate storytelling as a method to staff education? Sarah?
Yes, we do actually. We ensure to do that specifically at our winter meeting where we're all together. We talk about sort of the year at a glance, and we really focus on some of their experiences, as well as at the board level. Kim's just prompting me here. Is we've provided at every board meeting we start with a patient or client story, and so a client is invited to the board meeting as well as a staff member. So we rotate. So one meeting we have a client, one meeting we have a staff member.
So that brings us to the end of our first webinar. We appreciate everybody who attended, and we appreciate all of your very thoughtful questions. If there are any further questions, please feel free to email Michael or myself. You can also get in touch with us at quality@E-QIP, that's E-QIP.ca. We'd love to hear from you, and we look forward to our next webinar. Thank you, everybody, so much for taking part, and thanks especially to Jenna for your technical support, and to Kim and Sarah for bringing your expertise to this topic. Thanks, everybody.
Thank you.
Thank you.
Bye.